You're watching the Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, advances in spine surgery. With us, we have an expert on the topic. He is Dr. Tehernia. Dr. Tehernia, welcome to the program.
Thank you, Randy.
Now, we've wanted you on the show for many years, probably from the first time you entered the desert. So you're with the Eisenhower Medical Center.
Correct.
And you're also Director of Spine Center at DOC. Tell us about your role at Eisenhower.
Well, I'm the chairman of the department at Eisenhower for orthopedics. Okay. And I'm as you had mentioned, I'm the director of the Spine Center at Desert Orthopedic Center. I've been at Eisenhower now for 6 years. So
as a spine surgeon, who's your typical patient? What type of surgeries are you doing?
Well, the typical patient is patients that typically have pain radiating down into their arm or down into their leg, numbness, tingling, or weakness. They've been through a considerable amount of conservative care, usually physical therapy. A lot of times they undergo pain management, such as epidural steroid injections or selected nerve root blocks, other modalities that haven't really worked.
So by the time they get to you, they've tried all that stuff.
By the time they get to me and they really become surgical candidates, they have tried most of the other conservative mechanisms to try to treat their pain, and it just hasn't worked.
Now, people are afraid of the spine surgeon, aren't they? When you hear a spine surgery,
sure,
that's worse than a dentist, right?
That's what my patients tell me. They would rather go see a dentist than have spine surgery at times.
Is there number one fear that they're going to be worse off than before they even went in? I mean, what do you hear?
I think there are probably two fears. I think the first thing is they seem to have a friend or family member that had spine surgery done. It didn't work out well for them.
Okay.
I think the other issue that they have is that they think that there's a long or protracted recovery time with the spinal surgery. And with a lot of techniques we have available, some of the newer technology, some of the minimally invasive techniques, the results are actually quite predictable and the recovery is very quick.
Eisenhower, and DOC, you're known for firsts. A lot of firsts there. You're doing some unusual things there, not unusual, but first. Tell me about that.
Sure. We've had a lot of different research studies that we've channeled through Eisenhower. We've done cervical disc replacement at Eisenhower.
Really?
We've done vertebral augmentation to treat compression fractures with newer products available on the market that will be available on the market very soon. And the newest thing we're starting to do is a lumbar facet joint replacement, which has not been FDA approved, but it is going to be part of a new research protocol that we just started.
So it's part of a study, but you're doing them now?
We have just received IRB approval near the end of March, and we're enrolling patients right now.
Okay, what else is new?
Those are really the fanciest things that we have going on right now. I think that in terms of what else we're doing with spinal surgery, just really becoming much more effective at minimally invasively treating problems. And basically getting patients out of the hospital more quickly and getting them back to the things they like to do more quickly.
Is it true that somebody could have spine surgery and within a day they go back, they could go home?
In fact, that's true, Randy. In fact, a lot of my patients do. If a patient has a herniated disc in their neck or their back, typically at most they'll stay a day. The cervical disc surgeries that I do, the patients typically stay overnight. And the lumbar disc herniated surgeries that I do, I give my patients the option to go home the same day. And
Can they walk after these surgeries?
In fact, they have to walk before they go home.
Really?
They have to meet certain physical therapy criteria before they're able to go home.
Now let's begin with your background and training. I mean, you're published scientific articles, you present, you lecture to other doctors. Tell me about that.
My training goes back to medical school and residency at University of Pennsylvania. Then I did a spine fellowship, which is an additional year of training at the University of Colorado. And I'm now in my 10th year in practice, and I do have the opportunity to give lectures locally and nationally, and it's really a fascinating field of medicine to be into because it's a very dynamic field of medicine.
So it has changed quite a bit. I mean, over the last 20 years?
Even over the last 5 or 10 years. I really enjoy giving lectures even to our community, and I tell my patients or the folks that come to my lectures that things that I'm doing now I didn't do 3 years ago.
Really?
And things that I'm doing 3 years from now, I'm not going to be doing today. So it's a very dynamic field of medicine.
So what has changed the most? Just the fact that it's minimally invasive now?
It's really a combination of things, Randy. We've become much better at doing the same kind of surgeries through with smaller incisions, shorter recovery time, but there's also new technology available. And what we've really tried to move towards is technologies that maintain motion as opposed to eliminate motion, which was something that was very, very common years and years ago.
So if I talk to an old crotchety medical doctor, and our show now airs nationwide in Canada.
Sure.
If they say, spine surgery, you go to a spine surgeon, all they want to do is surgery. So lay some misinformation rest here. That's just not the case. It's not the way your mind works.
No, it's really not. In fact, patients that come and see me, even though they may be surgical candidates, if they haven't had physical therapy or epidurals, and I think that's a better course of treatment for them, I'll certainly try that first. And in a lot of patients, that actually does the trick.
And a lot of pain doctors, not just within DOC or Eisenhower, they send you patients that are outside. Is that correct?
They do, yeah, absolutely. I've got a pretty large referral pattern even outside the Coachella Valley.
So surgery is a great option. Would you also say this, that there are, I don't know, hundreds or thousands of people in the Coachella Valley that are suffering that don't have to be with some of the procedures you're going to talk about today?
Yeah, absolutely.
Really?
And I think the main reason that they maybe steer clear of spinal surgery are the preconceived notions that we talked about, that either it's going to be incredibly long recovery time, or for some reason they really fear the risk or the possibility that they may actually get worse. And if the surgery is done for the right reasons and it's done technically well, the results are very, very predictable.
Really? So, I mean, do you ever do spine surgery on a golfer and they're able to golf again?
Absolutely.
Really? All the time?
All the time. Golfers,
Okay.
tennis players, people that like to hike, or people that just want to have a better quality of life.
All right. Okay, let's start with cervical disc replacement, one of the things you do. Help me understand that.
Well, basically, cervical disc replacement is kind of an offshoot of what we already do in orthopedics. So we do hip replacements, we do knee replacements. And when we work in the cervical spine, most of what we do involves removing a portion or all of the disc to be able to achieve the surgical goal. When you remove the disc, up until now, what we basically have been doing is we've been fusing the bones together. And we've been using a combination of plates, screws, maybe a piece of bone from a cadaver, for example.
Okay.
And it's actually a very good surgery, but there are some downsides. Now we have the technology available to be able to actually replace the disc. So we put a prosthesis that is very similar to what you might have in your hip and knee, a combination of either metal or polyethylene, the plastic core, and allow or maintain motion. And in some instances, if the segment itself is arthritic, you can actually improve range of motion as opposed to what they had preoperatively.
So these are motion sparing?
Correct.
Is that what you call it?
Absolutely. I think that's really one of the big trends now in spinal surgery, is finding a way to provide the care that you need for your patients, but also maintain motion as much as possible.
Interesting, because when I think of it, and knowing that you were going to come on the show and anticipating it, I said, what are your thoughts about spinal surgery? And everybody says, well, that you're going to be stiff. You may be out of pain, but you're going to be really stiff. And so that's really misinformation, you're saying.
It is misinformation. I mean, obviously, if you have a particular part of your body, whether it's the neck or the lumbar spine, for example, fused over multiple segments, of course you're going to be stiff.
Okay.
But those types of surgeries are actually very uncommon. And there are also instances where we do surgery, again, going back to why we do surgery, we take pressure off the nerves. If there's not a reason to eliminate a motion segment or to do a lot of aggressive surgery, then a fusion's not even indicated anyway.
Okay.
And patients get back to, they basically are able to maintain their same kind of motion that they had before.
So is one of those a cervical disc replacement, your models?
Yes, it is. What we basically try to do with the cervical disc replacement, as I had mentioned previously, a lot of the surgeries that we have to do that requires taking the pressure off the spinal cord or the nerve roots, that does require removing the disc. And now we're able to use a product that actually replaces the disc with a combination of metal and plastic, and it really maintains excellent motion. We have patients now that are 2 to 3 years out of our research protocol, and we follow them along, and they've maintained wonderful motion.
How new is this?
This is relatively new.
Like a year, 2 years old?
Probably about 2 or 3 years old, give or take. Again, it's relatively new technology. The concept has not been new, but the technology is very new.
So is this similar to shoulder and knee?
It is somewhat similar. The spinal joint is a little bit more complex, but certainly the idea is to try to mimic the motion that's already there.
This is in the neck.
Correct.
Okay. And so what took so long for this technology to come out? Since you've been, doing knees and...
That's a very good question. I think there were attempts at this kind of technology, but the biomechanical testing and the products didn't match what you needed to do. In other words, there may have been other implants that were attempted, but you really need to have a combination of good wear characteristics for the implant, but you also need to have the proper fixation, and you always have to work around the nerves, which makes it much more complicated than a hip or a knee replacement.
So in the neck, if you have one problem with a disc, this is a great procedure.
This is a great procedure if you don't have too much arthritis, as opposed to a hip or knee where you want end-stage arthritis. You're not replacing the entire motion segment. The motion segment is made up of a disc and a couple facet joints in the back.
What about incisions?
Incisions are very, very small. They're usually about 3 or 4 centimeters in length. When the incision itself actually matures, it basically heals in line with your skin lines, and it's very, very hard to see. So it's actually a very cosmetic incision as well.
So is this one of those Eisenhower first? I mean, nobody else is doing this in DOC?
That's correct, Randy. And really the ideal candidate for this particular type of procedure is someone who has a large herniated disc, relatively young, so there's not severe arthritis in the neck, typically at 1, maybe 2 levels, where you have tremendous amount of pressure on the nerve and or the spinal cord, have significant pain, numbness, tingling, or weakness in the arm, and you failed other conservative measures.